about the concept of evidence-based therapy, which has become quite the catchphrase lately. For those of you who have followed the history of it, this term is well, the currently preferred term that has evolved over time. It began as empirically validated therapies, and then it became empirically supported therapies. Now the same therapies are referred to as evidence-based therapies. And we need to ask whether the slides are advancing. And evidence-based no longer means what it once meant. The term evidence-based really comes from medicine. There was a movement that developed prominence in the 1990s for what was called evidence-based medicine. And it was actually a very good idea at the time. It was really a call for critical thinking. And the idea behind it was that a good reason for doing something a certain way was not, we've always done it that way. That we really should examine all available information about it. We should consider our clinical knowledge and observation. We should consider our patients' preferences and responses. We should consider available empirical research. So it was a call for critical thinking. But what's happened over time in the psychotherapy world is that the term has been appropriated, almost as a proprietary brand for certain kinds of therapy. So, I'm going the wrong way. And what evidence-based really is, as the word is used de facto, is that it's become a code word for, it almost invariably means very brief, always manualized, highly structured forms of CBT. Almost always. There's some limited exceptions. But essentially, evidence-based is a code word for that. And manualized, for those who are not familiar with the term, literally means that the treatment is conducted according to a treatment manual. There's an instruction book. And there's a range of different kinds of manuals, but some of the more concrete are literally, in session 1 you do this, in session 2 you do that, in session 3, and so on. So there's really not much room for understanding of the individual. It's simply a prescriptive program. All of this has given rise to what I call the master narrative in the field. And the abridged version of the master narrative goes something like this, that in the Dark Ages, therapists practiced untested and unscientific forms of therapy, by which they mean psychoanalytic and psychodynamic therapy. And now, in our enlightened age, science shows that evidence-based therapies are superior. Not only are they superior, they're the gold standard of care. And I'm going the wrong way. And this movement toward evidence-based therapy has actually become the justification for an all-out attack on psychotherapy, as most of us who work with real patients in the real world have traditionally practiced it. That is, psychotherapy that fosters self-examination and self-understanding and insight in the context of a meaningful relationship between the therapist and the patient. So, what are they saying? These are some things that some of the most prominent researchers in the field are saying about so-called evidence-based and traditional therapy. Stephen Holland, who's a very prominent empirical psychotherapy researcher, says, the empirically supported psychotherapies are still not widely practiced. As a result, many patients do not have access to adequate treatment. And you'll notice the little linguistic turn that statement took. If it's not one of these evidence-based treatments, that is to say, manualized CBT, then it's inadequate. That's actually one of the more cautious and reasoned statements that one sees in the literature. This is Walter Mischel, who's a professor at Columbia University. The disconnect between what clinicians do and what science has discovered is an unconscionable embarrassment. So make no mistake, this is not a movement based on asking us to think critically about how to be most effective in helping our patients. This is a movement based on attacking psychotherapy as most clinicians in the real world have always practiced it. When this gets into the media, things get worse. This is an article from the venerable Washington Post. I'm not putting this slide up there with the intention that you read it. I just want to make the point. The article goes on to compare psychologists who are not practicing evidence-based treatments to pre-scientific medicine when, quote, healers commonly used ineffective and often injurious practices such as blistering, purging, and bleeding, and application of newts and leeches. The Los Angeles Times, another respected American paper, do therapists know what they're doing? Don't bank on it. And there's a kind of McCarthyism that takes over. That is, since they've claimed and appropriated the term evidence-based for their own usage, it makes it very, very difficult to have an intelligent conversation about any of the issues. Because if you question it, the immediate response is, you mean you're against evidence? You're against science? And so you see headlines, why do psychologists reject science? You would think in light of all of these claims, assertions that are being made on behalf of so-called evidence-based therapies and against psychodynamic or insight-oriented therapies, there must be amazingly strong scientific evidence demonstrating the benefits of these new therapies. There isn't. What we actually have here, how this situation developed, is that there's a yawning chasm between what we're told that research shows and what research actually shows. You see, very few people in the field are reading the original sources. Most of us really are forced to rely on having certain academicians interpret to us what the literature says. And so we get a gap between science versus the buzz about science. Actually, I left out something I wanted to say. Since my introduction mentioned that I was a ski instructor. You know something has become a buzzword. That is, it's become completely divorced from its original meaning and context when it becomes used for marketing and sales. I was actually in a ski shop in Vail, Colorado, where I'm a ski instructor. This was last season, and I walked into a shop and there was a large banner on the wall above some ski clothes, and it said, evidence-based apparel. So, you know, we've gotten into this mindset, evidence-based is good, and if it's not evidence-based, well, you know, then it must be bad or deficient in some way. What research really shows, is that so-called evidence-based therapies are ineffective for most people most of the time. So what I'm going to talk about today, this is kind of a part one and part two to the rest of my lecture. And part one is I want to talk a little bit about what research really shows, not what we're, not what the pundit, not what the, what's the word I'm looking for? The proponents and advocates of these brief manualized therapies would like to tell us about research, but what research really shows. And part two, I'd like to take a closer look with all of you today at some of the common research practices that are going on in this field that might make your hair stand on end. So what research really shows, I'm going to use the abbreviation EBT for evidence-based therapies. Evidence-based therapies are weak treatments. Their benefits are trivial. Most patients do not get well. Even the trivial benefits don't last. Now, this may be very different from what you've heard from virtually all other sources of information in the field. So you may be thinking at this point, who is this guy? Who is this American? And why should I believe him? Well, I'm going to return to that question again toward the end of my talk, but you shouldn't believe me because I've come armed with some primary sources, and I'm going to give you some examples of what I'm talking about. So I'd like to go back to the beginning. The mother of, so what's considered the gold standard of evidence in empirical research is the randomized control trial. And a randomized control trial is simply that we take a group of patients with a certain condition, we randomly assign half of them typically to receive a certain treatment, evidence-based treatment, manualized treatment, half of them are assigned to some form of control group, and we look at the difference between these groups. The mother of all randomized controlled trials was the NIMH, whoops, still going the wrong way, the National Institute of Mental Health. It's a government, United States government funding agency that funds the lion's share of health and medical research. National Institute of Mental Health Treatment of Depression Collaborative Research Program. It was the first really large multi-site treatment research program studying what have come to be known as evidence-based therapies. And it actually compared 3 treatments plus a control group. And the treatments were manualized cognitive behavioral therapy, manualized IPT or interpersonal therapy, an antidepressant medication, and then there was a control group that received a placebo pill and supportive meetings with a psychiatrist who really was monitoring their medication and offered some support and encouragement, but made no attempt to treat them. This was about 25 years ago. The study was initiated in the mid-70s. The first big publication started coming out in the 90s. And for all of these 25 years, we've heard in the field repeatedly that what this study shows is IPT, interpersonal therapy, and antidepressant medication are all empirically validated treatments for depression. And we've been told it over and over and over again for 10 years, or 15 years. It was I don't know how it was here, but it was impossible for me to go to a conference, either for mental health professionals or for physicians, for GPs, and not hear somebody, some speaker, refer to these findings, and refer to this, and based on these findings, basically advise practitioners that these were the 3 treatments that were scientifically shown to be helpful for depression. These were the treatments that science says we should provide. Well, I don't think anybody was actually reading the original research publications. So I'm going to focus on CBT because that's what gets the most attention, and of course that's the theme of today's conference. The claims for the benefits of CBT are based on the finding that CBT was statistically significantly more effective than the control group that received placebo. Very few people really take in what the word statistically significant means. I'm going to return to it. It doesn't mean what we think it means. So whatever preconceptions you might have about the word significant, I'm going to ask you to put them aside, and we'll look at what actually was the difference between the treatment CBT group and the control group that received the sugar pill. The primary outcome measure was the Hamilton Depression Rating Scale, a widely used measure. It's a 54-point scale. The difference between the treatment and the control group was 1.2 points on a 54-point scale. .2 points. It is an utterly... Can we hear? Are we losing sound? It is an utterly trivial finding. I'd like you to take a look with me at the actual Hamilton Depression Rating Scale. It looks like this. It's a set of items. Each item is rated. These are the first 2 pages. It's 21 items, and your score is added up. But I want to show you what a 2-point difference really means. So let's just hone in on, I don't know, item 15. This is rated, by the way, by a doctor or a researcher, not by the patient himself. Item 15, those are the possible rating choices. So if, for some reason, the interviewer or the doctor decides on that particular day that the person is more preoccupied with their health, or rather has a querulous attitude instead, that right there accounts for 2 points. That's it. We didn't get 2 points. We got 1.2 points. On the patient self-reported Beck Depression Inventory, it wasn't even 1 point. This doesn't pass the so what test, the common sense so what test. It doesn't pass the does it matter test. It doesn't pass the why should I give a damn test. It is a meaningless, trivial, irrelevant finding. It doesn't even come close to passing the so what test. Maybe the original researchers didn't present the data clearly. Maybe they distorted the findings or wrote things up in an ambiguous way that allowed people to misinterpret what the findings really meant. So I pulled up the original publication, the first major outcome study that came from this. This was it. It was published in Archive General Psychiatry. I'm just showing you the first page in the abstract. Let's just zoom in on a sentence in the abstract, a highlighted sentence here. There was limited evidence of the specific effectiveness, limited evidence of the specific effectiveness of interpersonal psychotherapy, and none for cognitive behavior therapy. That's what the original researchers wrote. In the 1990s, when the study was sort of reaching its end, and people are actually still analyzing data from that study. It generated just an enormous goldmine of research data. The lead author, Irene Elkin, wrote a lengthy, detailed, comprehensive overview of what we'd really learned from that study. And you have to remember, put this in political context. This was funded. The study was funded by people who were very invested. Nobody does a study hoping to prove that what they believe in is wrong, right? So this is a study with people behind it who are very invested in CBT, these manualized treatments. So obviously the researchers who write up the results need to be very politic and careful and cautious in how they write things, and she was. But she was also quite clear. So this is from her summary, I suppose I shouldn't skip over this. This is from her study, her summary, many years later, published in the mid-90s. It's called the NIMH Treatment of Depression Research Program, Where We Began and Where We Are. And again, I've just highlighted certain sections, and this was written by the original lead investigator. What is most striking in the follow-up findings, they actually followed these people for 18 months, is the relatively small percentage of patients who remain in treatment, fully recover, and remain completely well throughout the 18-month follow-up period. And this small percentage is so small, it raises, and here's the careful language, it raises questions about whether the potency of the short-term treatments for depression have been oversold, in quotation marks. What was that percentage, actually? So it turns out that about 25% of the patients in the study actually got well and remained well enough into the follow-up period. 25%. Of course, another way of saying that is that 75%, the overwhelming majority of patients treated in this study, did not get well. But how can this be? We've been told the opposite for the last 25 years. We've been told that manualized CBT is powerful and effective. And at this point, I'd like to revisit the term significant, because there's a certain sleight of hand that goes on, and I'm not even sure that it's fully intentional, but that in the English language, even in our bastardized American English, the word as used in everyday language is really a synonym for when we say something is significant, we mean that it's something important, something meaningful, something of consequence. But that's not what it means in statistics. In statistics, it's actually a term of art. It's a very specific technical term with a very specific technical meaning. And all it means is that a difference that you observe, a finding, probably didn't happen by chance alone. So we found a 1.2 difference between the control group and the CBT group in this study. It's a clinically irrelevant finding. Nobody would even think to dispute it. But it was statistically significant, meaning that the 1.2 difference probably wasn't a coincidence. That's all it means. There's no other field, well, there are some other fields, there are a few other fields, where people talk about something being significant instead of telling you the actual benefit. When any researcher talks about research findings and emphasizes the significance of the finding, you really should be very, very suspicious, because something is being hidden. When something changes in a meaningful way, one talks about the amount of change. So, for example, if we had a drug that was intended to lower blood pressure, we would talk about this drug decreased blood pressure by so many millimeters of mercury. There's actual meaningful units behind it. If we had a program that was designed for weight loss and it had any meaningful effect whatsoever, we would say that the average person in the study, lost 25 pounds or 30 pounds or whatever. Or if we had a cholesterol-lowering drug, similarly, we would talk about how much it lowered your cholesterol level. We would not talk about significant differences. Any time a researcher talks to you about the findings of research and emphasizes significance, take this home with you. Something is being hidden from you. Well, that was 25 years ago, though. Surely CBT has gotten better. Certainly research has improved. There have been hundreds of studies, if not thousands of studies, since then. Certainly the situation must have changed. Certainly treatment benefits have been just getting better and better. So I thought we'd do a little sandwich. I thought I'd start with the beginning and jump to the most recent, highest quality, state-of-the-art randomized control trial, just so we get the starting point and the ending point, because the middle is really largely the same. And the newest state-of-the-art research, randomized control trial, actually came out of Holland. 341 adults. This was interesting. They didn't have a placebo control group. They were randomly assigned to receive either CBT or psychodynamic treatment. 16 sessions. So again, these are both very brief treatments, and they were both manualized. Treatments were provided by psychologists or psychiatrists. The therapists were quite extensively trained. This was published in 2013 in the American Journal of Psychiatry. And I thought I'd just skip ahead to the discussion section, to the whodunit part. One notable finding was that only 23% of the patients achieved remission. State-of-the-art manualized CBT and psychodynamic therapy. Our findings indicate that a substantial proportion of patients, well, it gets very wordy here, require more than time-limited treatment to achieve remission. Let's come back to this number. 23%, about 25%. Only 22.7% of the patients achieved remission. In other words, about 75% of the patients did not get well. It's exactly the same finding. How much more compelling can it be when across a 25-year span, you're getting pretty consistent, not pretty consistent, you're getting almost identical results? The clinically appropriate conclusion to be drawn from both of these major research projects is that these treatments are ineffective for most depressed patients most of the time. Only a very small percentage of patients are getting well. The world of difference of telling a prospective depressed patient who's contemplating treatment, or to whom we're offering treatment, we're going to offer you this CBT treatment, brief manualized CBT treatment. It has been shown to be a powerful and effective treatment. Patients who receive this treatment get significantly better than those who don't. We're telling the patient, actually, this doesn't work for 75% of the people. It's about a 25% chance that it might work for you. Kind of changes everything, doesn't it? So let's talk about, we got the sandwich, the earliest big study, the most recent state-of-the-art study. What about the stuff in the middle? And there was a paper by a number of people. The lead author was my colleague Drew Weston. It was published in 2004. And it's really a detailed, comprehensive literature review of everything we know, everything we knew at the time about what was then, well, what's now called evidence-based therapies. About these brief manualized treatments, primarily CBT, for depression and anxiety. And really summarizing from his paper, the average depressed patient who receives one of these so-called evidence-based treatments actually remains clinically depressed after the treatment is over. Well, what about depression? Why does Shedler keep talking about depression? Well, first of all, it's the most common condition. There's the most research on it. But the condition for which these brief manualized treatments have been most effective is actually panic disorders. Well, what about panic disorder? The average patient treated for panic disorder, still successfully treated after treatment, still has panic attacks almost weekly, and still endorses 4 out of the 7 symptoms in DSM-4 that were required to make the diagnosis. In other words, they're not getting better either. The benefits begin to evaporate almost immediately. So outcome is measured on the day treatment ends, and any measurement point taken after that, the benefits simply begin to vanish. The majority of the patients, more than 50% of them, seek treatment again within the next 6 to 12 months for exactly the same condition. Now, the minority who don't seek treatment again, that doesn't mean they're better. Some of them may be better. A lot of them probably just decided that psychotherapy is worthless and gave up on it. The majority of patients are seeking treatment again for the same condition. What else do we need to know? That's the, how am I doing on time? I've got what? Good. Then I'll fit in the backstory on this paper. Drew Weston and I went to graduate school together. This was considered a famous or infamous paper, depending on your point of view. I'm actually going to name names because in this case, it's, I don't need to protect the guilty. I'm going to name the names of the innocent. You know, there's quite a specific procedure involved when you submit an article to a peer-reviewed journal for publication. And one of it is that the submission is confidential and private, sent to peer reviewers who are under an obligation to treat the material as confidential until it's actually accepted and released for publication. Drew Weston was at Boston University at the time. His department chair was David Barlow, who was a very prominent advocate of CBT. No one had seen a draft of this paper except for a few of Drew's friends, including me, and of course the journal reviewers. Somehow a copy of that paper and a letter showed up on David Barlow's desk. And the letter said, David Barlow was the chair of the department where Drew Weston worked. And the letter said essentially, do you know what's going on in your department? Have you seen this manuscript? Put a stop to it. It's up to you to make sure that this is not continued, it doesn't continue to be submitted for publication. And to his credit, David Barlow did what he should have done. He did nothing. But the story came back. So I don't know how representative this is. What I can tell you is here is at least one instance of direct first-hand knowledge of an attempt to suppress findings that weren't consistent with what we're calling the master narrative. Part 2. I'd like to take a closer look with you at a good close look at the research practices that are going on that give rise to some of these claims about the benefits of brief manualized therapies. The first thing that you need to know is that when people report findings, most of the patients with the condition, most of the patients who present for treatment, who would want to be part of the study, don't get counted. I'm going to go over these points in some more detail. The control groups are shams. They're a joke. The treatments are not compared to therapy that you might receive in the community, therapy that you might receive from an ordinary practitioner. The idea that these therapies, evidence-based therapies, have shown superiority to other therapies is an absolute myth. Actually, myth is the kind word. It's a lie. And data are being suppressed, being hidden from us, and we can prove it. So let's talk about patients not getting counted. The first thing that you need to know, and this also comes from the Weston paper, is that in the typical randomized control trial for any of these so-called evidence-based therapies, about 2/3 of the patients get excluded from the study a priori. That is, they have the diagnosis, they're referred into the study for treatment, and because of the study's inclusion and exclusion criteria, they're simply eliminated from consideration. 2/3. Sometimes it's as high as 70 or 80% of the patients who are referred for treatment get excluded and don't get into the study. And typically the patients who get excluded are those who meet DSM criteria for more than one diagnosis, who have personality, some kind of personality pathology, who are considered unstable in some way, who may be suicidal. In other words, the 2/3 that are thrown out of the research study are exactly the patients we treat in everyday practice. Out of the study. You don't get counted. So let's do the math together. 2/3 of the patients are thrown out before the study even starts. Of the patients who get into the study, not all of them improve. Only about half of them show some improvement. So among the people who have the diagnosis and were referred into the study, we're now down to about 16%. Right? So about 1/3 of them, right, say 33%, get into the study. About half of those show improvement. So we've now shown some benefit for approximately 16% of the people who came with the diagnosis. Fewer actually get well, though. There's a difference between being somewhat improved and getting well. And of course, as I've already talked about, very few actually stay well. Let's look at that in graphical form. Here are all the patients. I call this the inverted pyramid of shame. Here are all of the patients who have the condition who seek treatment. These are the patients who actually are allowed to participate in the study. These are the patients who improve. These are the patients who get well. That little tip there is meant to represent the patients who get well and seem to stay well for any meaningful length of time. 5%, give or take. Scientific research has proven that these treatments are effective, have lasting benefits for 5% of patients with a given condition. For those who like pictures, here's another way to look at it. The iceberg represents all of the patients who have a particular condition, depression, generalized anxiety, whatever. The tip of the iceberg above the water are the patients that we're hearing about, that produce the results that are published in the literature. All the rest, we're not hearing about them. They're not being written about in the publications. They're not even getting into the studies. Second point, the control group is usually a sham. What do I mean by that? I mean, we're not comparing the evidence-based therapy to any legitimate, bona fide alternative treatment that's meant to work. The control group is usually a foil, invented by the researcher, who has a stake in demonstrating the benefit of CBT, invented by the researcher, designed to fail. I'm going to give you an example of this. And I've got to give you a specific example because it's so unbelievable. I feel like if I didn't put a picture of the actual article on the slide, nobody would believe me. So this was a study, a state-of-the-art, NIMH, government-funded study of treatment of post-traumatic stress disorder, PTSD, single incident PTSD. That is, the person had previously been okay, been healthy. They were exposed to a specific identifiable trauma, subsequently developed PTSD. And the study claims, if you read the title, or the abstract, or the discussion section, to compare psychodynamic therapy with a form of CBT called prolonged exposure therapy. So two groups, the CBT group, psychodynamic therapy control group. And this is what it says in the discussion section of the paper, and in the abstract as well. This is the conclusion that the investigators drew, that was then communicated to the media, that was then published in media outlets and communicated to the public and policymakers. CBT was superior to psychodynamic therapy, superior, in decreasing symptoms of PTSD and depression, and enhancing functioning, and increasing overall improvement. Research shows that CBT is superior to psychodynamic therapy. Anybody who read this article, and didn't read very, very carefully, anyone who read the title, or the abstract, or the conclusions, would come away with that impression. And that is, in fact, what the public was told. I'm putting up examples of these papers, and I'm happy to email references. You can pull them up yourself if you like, so that anybody here can access them, and you don't have to take my word for it. You don't have to believe the crazy American. You can read it yourself. If you read the fine print, here's what you learn. What about the psychodynamic therapists? Experienced, competent, knowledgeable psychodynamic therapists. No, actually, the psychodynamic therapists were graduate students. But they received training in psychodynamic therapy, so it was all right. It's pretty shocking, isn't it? They were trained for 2 days by another student in a research laboratory that's committed to CBT, not to psychodynamic therapy. 2 days of training. Gosh. But I haven't told you the best part yet. It's even better. The so-called and by the way, the therapists who provided the CBT were trained by the pioneer, the originator of this form of CBT, world-famous clinician, researcher Edna Foa developed this method. I think they received 10 days of training from her. But that doesn't matter. It's even better. The so-called therapists who were providing psychodynamic therapy were forbidden to discuss the trauma that brought the person to treatment in the first place. We come to treatment for PTSD because we've experienced a traumatic event. And the first thing that happens is your therapist is forbidden from discussing the traumatic event with you. Of course, the patients think that they're there for treatment for PTSD, so they bring the topic up with some frequency, or they attempt to. But this is covered by the instructions in the manual and so on. The therapists, the so-called psychodynamic therapists, knew exactly what they were supposed to do when that happened. They were actually instructed that when the patients brought up the trauma, they were instructed to change the topic. This is a state-of-the-art randomized control trial published in a prestigious top-tier research journal. If anyone practiced like this in the real world, it would be considered negligence and malpractice. In research, that's considered a control group and basis for making claims that CBT is superior to psychodynamic therapy. Can this really be? I mean, you just can't make this stuff up. The control group is usually a sham. Now, maybe Shedler is a little crafty. He just cherry-picked an exceptionally bad study to make his point. Well, actually, there's very thorough and comprehensive review of the research in this area. Bruce Wampold, who's one of the leading psychotherapy outcome researchers, was the lead author. It's a research team. It was published in 2011 in Clinical Psychology Review. It looked at all of the randomized control trials that were then available for both anxiety and depression. And their criteria for including a study was that there had to be a control group that was represented as another form of legitimate therapy or as treatment as usual, as people would normally receive it in the community. They looked at over 2,500 abstracts. They winnowed that down to 149 relevant studies that appeared to compare an evidence-based treatment with another treatment. And when they got all done, there were actually only 14 studies that actually compared evidence-based therapy to something approaching a legitimate control group. And here's what they found, and here's what they wrote. And I'm quoting, no interpretation, direct quote from the author, that this is actually also a term of art. When you read the psychotherapy outcome literature, they refer to, there are many studies that compare a certain evidence-based treatment to treatment as usual. And what they found was that treatment as usual were predominantly treatments that did not include any psychotherapy whatsoever. In other words, the so-called evidence-based CBT that the researchers were invested in demonstrating its benefits were compared to doing nothing. There was no psychotherapy. Sometimes treatment as usual was defined as their GP made a referral, suggested that they might want to consider getting psychotherapy. And of course, what we know is the vast majority of patients who get a referral never follow through and never get therapy. That was the control group for some studies. Or, alternatively, they were compared to control groups that involved supposedly psychotherapy, except like the study I just told you about, by way of example, the therapists were actually prevented from providing the kind of therapy they normally would. The control groups were a sham. I want to quote from this article. It was published, if I didn't mention this, in Clinical Psychology Review. It's one of the most conservative, prestigious, respectable outlets, for scholarly outlets for research in this area. And they concluded as follows. This is very careful academic language, so I'm going to say it my way after I read it to you. There is insufficient evidence to suggest that transporting an evidence-based therapy to routine care that already involves psychotherapy will improve the quality of services. In other words, if the patient is already receiving any form of psychotherapy, there is no scientific evidence whatsoever that that person would do any better by getting one of these so-called evidence-based therapies. The closer the control group got to being some form of legitimate treatment, bona fide treatment, any kind of legitimate treatment, the more the apparent advantage for the evidence-based treatment vanished. Right? So if the control group is a sham, it looks like evidence-based therapy is more effective. If the control group, the more the control group approaches any form of legitimate therapy, the so-called evidence-based treatment does not have an advantage. Evidence-based therapies have not shown superiority to any other legitimate psychotherapy. That is the scientific fact. It's not just my opinion. So the American Psychological Association did an unprecedented thing last year, or the year before last. They actually commissioned a blue ribbon panel of the top psychotherapy outcome researchers internationally in the country to comprehensively review the published empirical literature on psychotherapy outcome. And it is the official scientific policy conclusion of the American Psychological Association that evidence-based therapies have not shown any greater benefit than any other form of psychotherapy. Official scientific policy conclusion. And you can look it up on the web. It's available. It's a public document with citations, with an extensive bibliography documenting the basis for this conclusion. Just for comparison purposes, I want to return to the conclusion from that research review by the Wampold Research Group. Oops, sorry, skipped ahead one. There is insufficient evidence to suggest that providing evidence-based therapy to someone who already has access to therapy will in any way improve anything. Now, let's return to one of the comments made earlier that's very representative of what advocates of manualized CBT have been telling students, other clinicians, the public. Empirically supported therapies are not widely practiced. As a consequence, many patients do not have access to adequate treatment. Quite a difference between these two statements. This brings us back to the theme of my talk, that there is a yawning chasm between what research shows and what we're all being told that research shows. How am I doing on time? 2 minutes. Oh, good Lord. Really 2 minutes, 5 minutes. Data are being suppressed. Now there's a well-known finding, and this doesn't apply just to psychotherapy, this is true in medical research generally, that's called publication bias. And publication bias refers to the fact that studies that show positive outcomes, that show the desired outcome by the investigators, tend to get published, tend to get submitted for publication, tend to get accepted for publication. And studies that fail to show the desired outcome tend not to see print, don't get published. There's a lot of different reasons why that might be so, but it is so. It's actually, there's even a name for the phenomenon in the field. It's called the file drawer effect. For every study that you read about that's actually published finding, how many studies are there that don't show that result, inconsistent results, that are sitting in somebody's file drawer that never get heard from again? How do you demonstrate the non-existence of something? How do you demonstrate that there's file drawers stuffed full of studies that we're never hearing about? How do you show what's not seen? It turns out there's a way to do that. So, I'll show you how we do that. But you can actually estimate how many unpublished studies there are that are getting negative results. And there's some wonderful research done. The lead author on this study was Ellen Dreisen. It was a large meta-analysis, but they actually estimated, I thought I had a reference for you. Well, ask later and I'm happy to send it around. They actually estimated how much of the effect size, the claimed benefits for evidence-based therapies, this is for depression, how how much they were exaggerated or inflated due to publication bias. They came up with a range of 60 to 75%. Actually, the number is 75%. There was an outlier that accounted for when they analyzed the data in a sensible way. The claimed benefits are inflated by 75%. Or in other words, the actual amount of benefit that a patient is likely to get is about a quarter of what the literature would lead you to expect. So how do you see the unseen? How do you know something like this? And you know something like this by examining what's called a funnel plot. And it looks complicated. It's actually a very simple idea. If you take a very small sample, imagine you're doing a survey. Are people in the UK in favor of or against some policy? And you take a very, very small survey of 3 people. Your results are just going to be all over the place because 3 people just is not large enough to be a meaningful sample. You know, you draw the wrong 3 people and 100% are in favor of or 100% are against. So when you have very small sample sizes, you get quite a scatter, a big range of results. But as the sample sizes get larger and larger and larger, then the findings converge on something accurate. So if you graph the findings, in this case, the amount of benefit that a particular treatment provides, and you graph that against the sample size of the study, you get a plot that looks like a funnel, where studies with smaller sample sizes have a wider range of results, and studies with larger sample sizes tend to converge on certain values. And that's what it should look like if data are not being hidden. That is the expected result. In fact, what it looks like is something like the graph on the right. All the data points that are supposed to be here are missing. And that's just a crash course in how you estimate the extent of publication bias, how much data are being hidden from us, how many file drawers there are. What is evidence-based really supposed to mean? I started off by saying that it began as a good concept in the 1990s in medicine. It was supposed to, evidence-based medicine was supposed to be the convergence of relevant scientific evidence and patients' values and preferences and the experience and clinical judgment and wisdom of the practitioner. Evidence-based medicine was defined as the intersection of those 3 things. What does it really become in practice? Well, oops, what happened? Sorry about that. That's a different talk. Relevant scientific evidence doesn't matter because nobody is willing to talk about evidence for any other form of therapy other than these brief manualized treatments. Now, the 2010 paper that I wrote, that I'm best known for, The Efficacy of Psychodynamic Therapy, shows that actually the benefits for psychodynamic therapy are at least as large as those for so-called evidence-based treatments, and they're enduring, they last. But the evidence, the real evidence, is being ignored. We're only hearing about the evidence that serves a particular agenda. Patients' preferences and values become irrelevant because the patients aren't informed. They're not told the truth. They're not given a choice of possible treatments. What do they want? What might work for them? They're told, this is the gold standard of care. This is the right treatment. Nobody cares what the patient has to say. And clinical judgment, of course, is irrelevant because the clinicians are expected to follow a manual, not function as clinicians, function as technicians. So I would suggest that evidence-based, as the term is now used with respect to psychotherapy, is actually a perversion of every single founding principle on which the concept of evidence-based medicine rests. Who is this guy? Me. Why should I believe him? Everything that I've read from every respectable scholarly source from respectable people in the field, from my colleagues and conversations, people I know and trust. Everybody is saying something else. Why should you believe me? You should not believe me. You should not believe anyone. I'm going to leave you with 3 simple things to do, starting today, instead of believing me or anyone else. When somebody makes a claim for the benefit of some treatment, any treatment, all you have to do is 3 things. Okay? Show me the study. Give me a reference. Give me a citation. Give me a reprint, a PDF. Put the study into my hands. I want to see it with my own eyes. Much of the time, that study doesn't exist. But often it does exist, and somebody will put a study into your hands. And then all you have to do is read it. Read the fine print. And step 3, after reading the fine print, draw your own conclusion and ask yourself the question: do the actual methods and findings of this article, of this study, do they justify the claim that I just heard for what the study supposedly shows? And decide for yourself. And I would suggest that if you try this practice as a sort of ongoing exercise, you might be quite shocked at what you discover. Thank you very much.